afternoon, I'm Dr. Bancha Chernchujit from Thammasat University, Thailand. Thank you, the organizing committee, for an invitation. Thank my 3 fellows for preparing the information. Today, I'm talking about the approach to MDI and treatment. Congratulations for the successful meeting of SLAHOC 2021. I will start with the multidirectional laxity or MDL and how it's different from MDI or multidirectional instability. We should differentiate between MDI and MDL. This guy had loose shoulder but has no problem. If you test his shoulder, there's no pain. Generalized ligament laxity doesn't mean it is pathologic. MDI is MDL with pain. Symptomatic laxity at least 2 directions, but the main component should have inferior laxity or instability. It is about 10% of all instability, mostly female. The first mechanism is repetitive microtrauma, such as overhead athletes. Second mechanism is due to disorder causing generalized ligament laxity. For example, earlier than loss, Marfan syndrome, osteogenesis imperfecta. Patient number 1, she is inferior plus anterior instability, SLAHOC sign positive, hyperabduction test positive, and anterior apprehension test positive. Patient number 2, he has inferior plus posterior instability. He has SLAHOC positive and Kim test positive. Patient number 3, she has global instability, inferior plus anterior and posterior instability. She has SLAHOC and hyperabduction test positive, anterior apprehension test positive, and Kim test positive. MDI can be classified into 3 groups according to Pagnani and Wallen classification: born loose, taught loose, and acquired loose. Type 1, born loose. It is congenital MDI, global instability in all 3 directions, high Beighton score. For example, earlier than loss, Marfan syndrome, osteogenesis imperfecta. This is a true MDI. Do not operate in this kind of patient. Type 2, taught loose. Patients start with asymptomatic MDL and become symptomatic after repetitive microtrauma or single macrotrauma. This patient is a very active rugby player. I treat him since he was a boy, but finally he becomes an MDI guy. Intra findings, the scapulo-labral recess and labral tear. Type 2, taught loose, always needs surgery. Type 3, acquired loose, is the MDL with repetitive microtrauma, usually from overhead sports such as swimming, baseball, racket sports, tennis, badminton. Intra-finding, there will be scapulo-labral recess with no labral tear. Always start conservative first, surgery if indicated. MDI with posterior instability is a very common scenario. We can classify into 2 groups, voluntary and involuntary dislocation. The voluntary group can be classified into positional and muscular dislocator. The first patient is voluntary positional. He can subluxate his shoulder when performing flexion, adduction, and internal rotation. The second patient is voluntary muscular. He can dislocate the shoulder by muscle contraction, non-positional dependent. And the third patient, she is involuntary dislocation. She cannot control her shoulder dislocation. MDI signs symptoms. The classic scenario is the patient who had first-time dislocation from minor trauma, mid-length instability, and easily self-reduction. May have numbness, tingling sensation when carrying or pulling heavy object because of the traction of brachial plexus. Some patients may have scapulothoracic problem too, like this patient has wing scapula. These are the hallmarks findings of MDI. There will be scapulo-labral recess, no labral tear, no heel sac lesions. Sometimes we can see the concealed labral crack or Kim's lesion, as shown in the video. Now let's talk about the laxity test and instability test. The laxity tests are the tests that show joint laxity but not producing pain. For example, anterior and posterior drawer test. The patient needs to relax and drop the arm down. We can translate the shoulder front and back and not producing pain. SLAHOC sign is another laxity test. It represents the inferior laxity. Hyperabduction test more than 95 degrees also represent the inferior laxity. Beighton score more than 4 represent the generalized ligament laxity. Instability test is a laxity test that produces pain or apprehension symptoms. For example, anterior apprehension test. This test should be done very gentle because the shoulder can be dislocated during the test. 45 degrees represent the mid-length instability, more than 90 degrees represent the end-length instability. Painful hyperabduction test is considered as inferior instability test, but the hyperabduction test without pain is the laxity test. Painful jerk test is another instability test that represents the posterior instability sign. Kim test. This video is 16 years ago when I visited Dr. Sung-Ho Kim. This is a very good test for posterior inferior instability. We start most patients conservatively. We strengthen the rotator cuff and the periscapular muscles. Most surgeons agree that we should try conservative treatment intensively at least 6 months before jumping to do the surgery. Outcome is very good in bone loose and acquired loose, and they respond very well with conservative weight up to 90%. But in torn loose group, only 16% had good outcome. More than 80% need surgery. This 21-year-old MDI lady, after 6 months of conservative treatment, she become more muscular. The laxity and instability test getting better. Here is a young girl with involuntary shoulder subluxation. Look at her scapula, it's unstable. After I immobilized her scapula, the shoulder subluxation stopped. I remind her to do the scapular retraction with figure 8 and train her periscapular muscles. She is getting better after 6 months, really happy, and less uncontrolled shoulder subluxation. A lot of studies shows that MDI in the young may improve over time, so initial conservative treatment is always advised. The indication for surgery if the conservative treatment fail at least 6 months in MDI with labral tear, with involuntary instability, or with persistent painful jerk. The goal of surgical treatment is to restore the labral height, tighten the joint capsule, balance loose ligament, and repair the labral pathologies. The examination under anesthesia is important to determine the degree and direction of the dislocation. We published the TU supine position. It's good for the shoulder instability surgery. This position had less gravity effect and very comfortable for the surgeon and the patient during the surgery. Just regional anesthesia is needed. I prefer these triple instability portals. I start with posterior Kim's portal, 2 cm from the posterolateral corner. This portal is good for viewing and working, especially for the posterior and inferior labral repair. Followed by the anterosuperior portal, it's just in front of the AC joint. The last portal is anteroinferior portal. It's just lateral to the coracoid and above the subscapularis. Try to find the hidden lesion. This is a Kim's lesion. It's a concealed labral crack lesion at 6 o'clock. I refresh the repair site by fully detach the labrum. I'm not a fan of capsular plication. I find better results when fully detaching the labrum. I call this capsulolaboplasty, proposed by Dr. Sung-Ho Kim from Korea. I start at 6 o'clock position, and I prefer a double loaded anchor. Pancapsulolaboplasty was done from 3 to 6 and 6 to 9 o'clock. Finally, we always close the rotator cuff interval. We need at least 2 stitches. I also close the posterior portal. I try to close all the defect of the shoulder. Here are some cases. 24-year-old man, recurrent shoulder dislocation since he was 16. Shoulder examination showed anterior apprehension positive from 45 to 120. Posterior Kim test positive. I first saw him since he was a boy and treated him conservatively for 8 years. MRI had no labral tear. He is very active in sports, and finally, he had torn labrum. This is a good example of torn loose patient. Finally, I did the pancapsulolabal repair for him. From 3 to 6 and 6 to 9 o'clock. 25-year-old man, he's failed conservative treatment. He had anterior, inferior, and posterior instability with no labral tear. So, I plan to do pancapsulolaboplasty for him. I did the rotator interval closure and pancapsulolaboplasty, and his X-ray after surgery is getting much better. Here are some complications. This MDI patient was operated by Bancha repair without inferior capsular shift. So after surgery, the patient had painful inferior subluxation. This MDI patient after failed 3 surgeries. This MDI patient after failed 4 surgeries. This MDI patient after failed 10 surgeries, both sides, because she's bone loose earlier than lost. Take home message. MDI is not MDL. MDI is MDL with pain, with symptomatic laxity at least 2 directions. The born loose, try conservative first. Avoid surgery. The torn loose, 80% the patient needs surgery. The acquired loose, try conservative first. Surgery if indicated. Thank you for your attention.